Hi guys. So let us just start the session for today. I think I waited long enough. So how was the session for you guys? How was the assessment? Did you find any difficulties?
Hello.
Hello, Dr. Satorov. How was your assessment? Was it good?
I'm not. I'm not happy, with the result.
Bye.
Like because I was, like I don't know, but I was in rush, when I did it.
Mm-hmm.
But the time
Mm-hmm. So how much did you score?
score 60 something, I think.
Not bad, not bad. There is still room for improvement. So we always recommend to take the test whenever you're in a quiet, seated environment, when you're not in any rush, so that can accurately predict your score. And that also tells us where you're standing in terms of preparation and what else we need to focus on, so that it can strengthen your process of learning. And that is why we recommend it. But 60%, it's not a bad score. Good job, Dr. Satoru.
Yeah, but like I'm just worrying that my test gonna be, like by the end of the April.
Hmm. No,
Yeah.
you'll improve. You'll improve. Don't worry about that. But I think it was the reason that because you took it in such a rush, and I think that is why you got some questions wrong. That might be the answer. So next time, try to take the test in a quiet and seated environment, because these are very predictive of your test score. All right.
Yes, you're right. Yeah, like when I just check the, like incorrect question answers, I saw, like, oh my God, I never should do this because I knew that one, but I did.
Mm-hmm. No, I mean, just you know the answers. Just try to read through the concept, read through the question first, and then pick an answer. All right.
All right, thank you.
You're welcome. Okay. Let's start with the assessment. I will be sharing my screen so that you guys can see. All right.
Hi, Dr. Maheen. You never shared the high yield questions from yesterday.
Yeah, so I talked to Dr. Hamza about it, and he told me that this was, a live Q&A session sort of thing. So I shouldn't share the questions.
But
So
it wasn't even recorded and all the timing doesn't work for me. I have drop off and pick up. I was driving.
mm-hmm. We understand that, but it was more of an interactive session. So I think that is why they did not record it. Usually they record the lectures. For example, if they're giving any
Okay.
lecture, we are giving like a UWorld session, that's recorded for you to understand. But it was more like of a Q&A, a rapid fire question session. So they did not feel the need to record the session. And I think
Okay.
I just asked a lot of questions from what I wanted to ask at that time, and after that I did not even remember half of the questions I asked, so it was impossible for me to write down the questions and then send it on the group. All right.
Okay. Thank you. Thank you.
All right, you're welcome.
Thank
Okay,
you.
so let us
Dr.
start.
Maheen, sorry, please, can you increase it? Oh, okay. The
Yeah, no,
font?
no, 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 I'm increasing it. I
Okay,
was
thank
just
you.
talking. All right. Okay.
Uh,
All right, we
Another
go.
one thing. Yeah.
Yeah.
Can I say anything?
Yeah, sure.
Yeah. So, one thing that is bugging me is since we are doing the assessment just after doing those questions in UWorld, so we kind of most of the time have a vague memory or the memorize those questions. But I fear when we will after a long time or when will there will be a considerable gap. I feel like we will forget those things. So how can we uh, deal with that?
Just revision again and again. Trust me, we're all doctors. We all forget stuff. It is impossible for me to memorize every ligament, every nerve. Even I forget it. So it's okay. It's completely normal if you're forgetting it. The only way that it can stick to you is just by root memorization and then revising it again and again. So the more you go and revisit the concept, the more it's going to stick to you.
So for revising, you mean going through the questions again or doing Anki or anything like that?
No, not going through the questions again, just going through the concept. and try
Okay,
to
so that
solve
means
as many questions as you can.
okay. So going through the first aid and Anki, and if possible, we can try for
Yeah,
another
any,
Cuban.
for
Right.
example, if you forgot the muscles, if you forgot the rotator cuff muscles, for example, right? Go and visit the rotator cuff muscles from first aid, all right? Solve as many questions as you can, because the more questions you're going to solve, the better it's going to be for your exam performance. So that is why I'm saying, if you're forgetting something, just go through the concept again wherever you feel comfortable with. If you want to go through first aid, if you want to go through Anki, wherever you want to revisit that concept from, just kind of grasp onto that concept again, and then try to solve as many questions as you can.
Got it. Okay. Thanks.
Okay, so we'll start with the assessment session. So we have this first question. There's this 12-year-old girl. She's brought to the ED following a sports injury involving the right lower extremity. Patient was playing soccer when she jumped and turned to the right. Okay, she landed on her right foot with her foot internally rotated and knee extended. All right. Since the injury, the patient has been able to bear weight. That means that it's not a fracture, but says her knee feels unstable and she's afraid that it might give away, okay, causing her to fall. Stability testing shows excessive anterior translation. I think I discussed this yesterday. Yes, so what do you think the answer is?
ACL
Anterior,
injury.
anterior cruciate ligament injury.
Exactly. So we discussed this yesterday as well. If it is anterior translation, that's ACL. If it is posterior translation, it is the PCL injury. All right. Okay, so let's go to question number 2. What is happening over here? What's this?
It's fracture.
Scaphoid fracture.
Scaphoid fracture.
Where do you see the scaphoid fracture? Where is it?
On the right side here. Uh, yeah, this first bone. Yes.
Oral attachment.
Very good. Okay, now let us see that what have they asked. So they have asked us that this is a picture of the fracture, and they're asking greatest risk of developing. What are the complications? I told you guys this.
Yes.
I did-
Avascular necrosis and non-union.
Very good. Eye vascular necrosis and non-union. So we are familiar with the concept. All right. 37-year-old woman, ED, following a motor vehicle collision. She lost control of her car while going around the corner. All right. Examination shows that the left lower extremity is adducted and internally rotated. I think I also discussed this yesterday. What's that?
it's posterior movement. Posterior
Sciatic
movement.
nerve injury.
Very
This
good. That will be
Yes.
the
posterior
sciatic.
dislocation of the hip.
Sciatic. All right, that will be the posterior dislocation. In anterior dislocation, what happens?
Femoral nerve injury.
Femoral nerve involved.
Very good. We discussed it already. All right. Okay. 34-year-old woman comes to the physician complaining of easy fatigability. All right. She lives alone. Menstrual cycle is regular. All right. Her last menstrual period was 2 weeks ago. Does not smoke. Blood pressure is very high. Pulse is okay. Physical examination. She sits up from the supine position without using her hands. Oh, yeah. This is a URL question. What did she use?
SOAS.
Sauce.
So
Yeah.
very good. We also discussed this thing called psoas abscesses. Psoas abscesses, in what conditions is psoas abscess found?
Diabetes.
Very good.
TB.
Diabetes, tuberculosis,
Hip.
yeah,
Then there,
osteomyelitis.
Very good. Most commonly in immunocompromised patients, you will see the psoas abscesses will present as flank pain. All right. Okay. So we have a 12-year-old girl. All right. Constant swelling and pain of her elbows for the past week, knee pain. All right. Okay. Then patient temperature really high, elbows are swollen, ASO titers are really high, holosystolic murmur. What do you think is happening? What's happening?
mitral regurg, rheumatic fever.
Okay, very good. It's rheumatic fever.
The mitral regurg, because of mitral regurg, the holosystolic murmur is heard. And the main complication is the pancreatitis.
Pancreatitis, yeah.
Very good. So we know that whenever a child has new onset of murmur, that's usually the rheumatic fever. All right. And okay,
Mhm.
so we see that it's pancarditis. Why isn't it mitral stenosis?
Stenosis is the late complication. Like,
Exactly. It is the chronic
chronic.
chronic rheumatic fever. It usually develops into mitral stenosis. First, we will have the mitral regurg, and then we will have mitral stenosis. So mitral stenosis is usually the end stage complication. All right. Okay. Then we come to the next question. There is a 62-year-old woman comes to the office due to activity-related joint pain in the hands and periodic morning stiffness. Okay, now that is lasting for 10 to 15 minutes. All right. Patient is attempted to treat the pain with acetaminophen, which provided only partial relief. Physical examination shows firm nodules over the DIP bilaterally. So it's bilateral DIP. What do you think is happening?
It's
Hypertension.
osteoarthritis.
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 Herpendens
Hy-
nodes, these are the Herpendens
Herndon
nodes
Hypertension.
nodes,
involving
yeah.
the distal joint, and the pain is not getting relief with the activity. It's also the point for the osteoarthritis.
Exactly. So yesterday I mentioned that they can also give you osteoarthritis of hand as well, and they gave you this over here. So all right, you need to be very familiar with the clinical presentation. We talked about how osteoarthritis is usually bilateral, and the stiffness it gets worse throughout the day. Whereas in rheumatoid arthritis, it gets better throughout the day. We talked about that, right? All right. Okay, we talked about gout. We talked about fibromyalgia. We talked about infectious glycoseptic arthritis. We talked about that as well. All right. What's this? What's happening?
Swan neck deformity.
What's this? What?
Ulnar
Swan neck.
deviation.
It's
Rheumatoid
the
arthritis.
rheumatoid arthritis,
And
ulnar deviation,
deformity.
subluxations of the fingers and the hands joints.
Swan neck
Yeah.
deformity.
Ulnar
Deformity.
deviation.
Ulnar deviation.
Ulnar deviation.
All
Okay.
right. So we are seeing a 61-year-old woman, and she began to have pain in her hands at age 30. Symptoms been intermittent but progressive. Symptoms were treated with NSAIDs, all right, hypertension, chronic anemia. So you see how they've linked, chronic anemia with rheumatoid arthritis. I told you that when we were studying the hematology module, that in most of the autoimmune conditions, you will see chronic anemia. All right, she does not have smoke cigarettes. All right, family history is insignificant, and then that is that. All right, so we know what this is, and what spine will it affect?
Cervical spine
Cervical.
is initially involved in the rheumatoid arthritis.
Cervical spine.
Most likely
Yeah,
cervical
it's
spine.
called atlantoaxial dislocation.
Atlantoaxial subluxations,
That
yes.
is why in every rheumatoid arthritis patient, before intubating that patient, you need to do a cervical spine X-ray. All right.
Mhm.
Before intubation, you need to check their necks. If you need to have X-ray of the neck, if there's a rheumatoid arthritis patient, before inserting endotracheal tube, and if the patient has a rheumatoid arthritis or atlantoaxial instability, then you do not intubate that patient, and because of the risk of atlantoaxial subluxation. All right. Okay. Then we come to the next question. All right, we have a 48-year-old woman comes to the office with a 4-month history of pain, stiffness, swelling of hands, blah blah blah. Okay, she uses NSAIDs, does not use tobacco, alcohol. She is obese, another risk factor, obesity. All right, patient
Mhm.
walks with limb due to pain in the foot, symmetrical, another giveaway, symmetrical swelling. All
Yeah.
right, there is no skin rash. Laboratory are showing anemia. What do you think is happening?
So rheumatoid arthritis, because it
Rheumatoid
is
arthritis, yeah.
lateral symmetrical involvement is the characteristic feature of the rheumatoid, and also the anemia is also there. So it is again the
Mhm.
rheumatoid arthritis, and the
Mhm.
initially we earliest finding we see the synovial hypertrophy. That's because and the options in
Fairness formation in the rheumatoid arthritis,
synovial
na? Yeah.
neovascularization will be the answer.
And there is
Exactly.
systemic swelling. Systemic swelling is also something
Stomach
important.
swelling.
So they try to confuse us this with osteoarthritis because they mentioned the BMI. So when we usually see obese patients, we think that, oh, okay, they might have osteoarthritis, all right. But then there are other things that are in the vignette that you need to see. For example, the bilaterality, the symmetrical nature, the anemia, and temporary relieved NSAID. So, all of this, you can see that. And it's a clear indication of rheumatoid arthritis. We have venous formation, that's the initial step. So we have synovial neovascularization will be the answer. Where do we see osteophyte formation? Where do we see that?
In
Osteoarthritis.
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 Very good. All right. Okay. Then we come to the next question. 70-year-old woman brought to the ED due to acute right hip pain after a fall. All right. Patient is unable to bear weight. All right. Very clear indication of something is going on. All right. Tree has no significant medical history. Patient's only medication, okay, multivitamin. Blood pressure is a little high. Hip fracture in our mother as well. Patient is moderate pain. Right leg appears shorter and external rotated. What happened? What type of dislocation is that?
Hip.
It's the
Anterior
fracture.
Posterior
Femoral neck
dislocation.
fracture.
Radiographs showing the
Yes.
neck
Anterior
Femoral neck
fracture.
fracture.
So it is the
Posterior hip dislocation.
osteoporosis.
Exactly. So whenever we see right femoral neck
Same.
fractures, which of the following changes in bone structure will be happening? So what do you think the answer is?
Osteoporosis. It's E.
Osteoporosis and the E will be the
trabecular.
trabecular thinning.
Thinning and the fewer interconnection.
Thinning of the interconnection.
Yes.
Exactly. So we'll be having trabecular thinning with fewer interconnections. Where do we see subperiosteal bone resorption, cystic degeneration? Where do we see that?
In hyperparathyroidism, we find the subperiosteal bone resorption, and the lamellar bone is seen in the Paget's. Osteoid matrix accumulation around the trabeculae, that will be seen in the osteopetrosis. Uh,
Hmm. All right. Anybody else? Does anybody else want to answer? All right. So we know that they're talking about osteoporosis. They're saying that, she's 70-year-old, she's old. In old age, we know they become, kind of vulnerable to osteoporosis. And that is why the patient had right femoral neck fractures. So this is a classic pathological finding in patients who are having osteoporosis. These are the lines present in first aid, pathoma. Go through them if you haven't. All right. Okay. Next question. 64-year-old man, right hip pain. All right. Occipital headaches. All right. He has autoimmune thing going on as well because, type 2 diabetes mellitus, it's autoimmune in nature. He is also a smoker. All right. He drinks alcohol. Physical examination shows increased AP diameter of the chest with hyperresonance on to percussion. What are they saying? What is this? What is this condition called?
This is
Increased AP. What's
COPD.
Yeah, that's UPD. Very good. So we're talking about we're talking about the barrel-shaped chest, right? It's a increased AP diameter, hyperresonance, air is stuck, and that is why it's hyperresonant. Normally, the percussion note is resonant. Whenever we see hyperresonance, which means air is getting stuck. In COPD, we see that the air is not able to kind of get out, and that is why it's obstructive in nature. All right, so which means this has got nothing to do with what we are going to discuss further, but because he was a smoker, that is why they kind of gave it in the WICNET. All right, serum calcium level and phosphorus levels are normal, but serum AKP is elevated. Again, the answer was in the last line. We didn't have to read it. That is why I always advise you guys to read it from the last 3 lines and then figure out. It saves a lot of time and energy. All right, it's isolated AKP. Where do you see that?
Paget disease.
yeah, Paget's.
Paget.
Very good. So you see that in Paget's disease. Okay. Then we come to the 11th question. All right, 60-year-old man comes to office due to 4-month history of increasing mid-thoracic back pain, which is aggravated by coughing. Okay, patient also had right thigh pain, but no numbness or weakness in the legs and no bowel or bladder incontinence. He has no other medical conditions. On examination, there's tenderness over the 8th and 9th thoracic vertebra. All right, neurological examination is normal. Imaging reveals enlarged vertebral bodies with cortical thickening. Serum testing for which of the following would most likely help diagnose the patient? What do you think the answer is? What's happening?
It's again the Paget's.
Paget disease. Yes.
Paget's. Because
All
the
right.
serum
Cortical
calcium
thickening.
and the other imaging is normal. So vertebral
Paget.
body is enlarged and cortical thickening is the Paget's. The alkaline phosphatase level gets high.
Okay, yeah. So we're talking about Paget's disease over here, and isolated alkaline phosphatase is the answer for that. All right. Okay. We come to the next question. 46-year-old man comes to the office due to right shoulder pain. Pain started 2 months ago after the patient began working at a new warehouse. All right. Okay, frequently moves heavy boxes. All right. He's been taking over the counter analgesics. All right. External rotation of the right shoulder against resistance is painful, but there is no weakness. MRI reveals near complete clear of the right infraspinatus muscle. Absence of weakness in the patient is best explained by compensatory hypertrophy. Which of the following? What do you think is happening?
Hypertrophy of the teres
Teres
minor will occur because that's the external rotator, and the infraspinatus tendon. If infraspinatus muscle is also function is the external rotation. So if that muscle get injured, the other the function because of compensatory effect, the teres minor muscle will get have hypertrophy.
Exactly. So usually the treatment. What's the treatment for these patients? What do we give?
non-steroid?
Steroids?
No, the springs.
No,
Shoulder.
none.
NSAIDs.
Supportive. Yeah, you always give supportive treatment for
Yes.
muscles. All right. Okay. Then we come to the next question. MRI shows thickening and calcification of the supraspinatus tendon. Which of the following arm movements, when performed against resistance, is most likely to provoke pain in the patient? What do you think the answer is?
Abduction.
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 Exactly. We know that supraspinatus kind of helps us with that. What is the adduction muscle? Which muscle does adduction of the arm?
All is,
Sub
It is
subscapular.
minor and
Subscapularis.
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 Mhm. What's
And it
responsible
is
for
minor.
flexion?
Bicep.
What's
Subs
Oh, okay. No, no. Shoulder joint. Sorry.
mm-hmm. Okay. All right. Okay. So we have a 10-year-old boy brought to the pediatricians by his mother because he's been complaining of difficulty using his right hand. He's found to have a right wrist drop. The loss of the which of the following muscles contributes to the patient's condition? What do you think is happening? Radial nerve
Extensor
injury.
group. Yeah. Extensor muscle getting
yes.
paralyzed.
Yeah, affecting the
Extensor
radial nerve.
carpi. Extensor carpi. Yes.
Exactly. Again, root memorization question kind of makes logical as well. For example, that's a radial side, and this is the only muscle
Mm.
having breaks with it. So it's kind of like a logical question as well. All right. Okay. Then we come to the next question. 50-year-old woman who works as a secretary comes to the physician because of numbness and tingling in hands. On examination, the patient is found to have decreased sensation in all of her fingers except the fifth digit. All right. Which of the following muscles is most commonly weakened? What's happening?
Median nerve injury.
Median nerve is involved, and that supply the only the adductor polishes. All
Yeah,
the
this
other
is
muscles are
carpal.
supplied by ulnar nerve.
Yeah,
Opponent's
this is
policies.
carpal tunnel syndrome.
No, it's opponent's poses.
So,
Both opponent's policies and adductor policies are supplied by median nerve.
then why isn't it the adductor policies over here?
Adduction, it's the function. The thumb adduction is
Is it by ulnar nerve?
that's by the ulnar nerve. Yes.
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 In opponent's policies?
It's the opponent's policy.
Ulnar nerve.
Yes.
Yeah,
Yes.
this is the right one.
Mm.
Adductor policies. Adductor policies
Adductor policies is
is a
irregular.
part of. It's a part of thenar
Ulnar.
muscle, right?
Ulnar
Adductor
nerve.
policy. Adductor policy is a part of thenar muscle. Am I wrong?
Anybody
Yes,
else?
the
You're correct. I was also
median nerve
confused
is
by
damaged.
this.
So the median nerve is supply the opponent's policies. That's the thenar muscle. Yes, perfect. It will be C.
Yes.
Yes.
So adductor policies is supplied by what nerve?
Adductor is supplied by ulnar.
Very good. And opponent's policies is supplied by?
Median.
Irregular.
Median.
So the adductor pollicis is supplied by the deep branch of the ulnar nerve, and opponens pollicis is supplied by the median nerve, and that is why when we see carpal tunnel over here, we know that in that median nerve gets injured, and that is why it's the opponens pollicis. The
Opponent
answer.
policies is the answer, yeah.
All right. Okay. Then we come to the next question. 52-year-old construction worker comes to the emergency department after being accidentally shot with a nail gun. Okay. In an attempt to localize the injury, the physician tests her reflexes and finds that she has an absent biceps reflex. What nerve is injured in the
Mus-
abs?
Musculocutaneous nerve.
Musculoskeletal, yeah.
Musculocutaneous, sorry, musculocutaneous.
Exactly. It will be the answer over here will be
D.
musculocutaneous biceps
Yeah.
reflex. It's kind of mediated through musculocutaneous nerve. All right. If either the ulnar or radial arteries are occluded, which arteries ensure adequate collateral arterial flow in the hand? What do you think the answer is?
The deep
In
deep,
superficial palmar
deep and
arch.
superficial palmar arches.
Yeah,
These are the
yeah.
collaterals. These are
Deep and
basically the
superficial palmar
collaterals of
arch.
the hands. Deep
All
and
right. Okay. We know it cannot be the pedis one because that means foot. We cannot have foot things in our hand. All right. So we know it's automatically not that. Arcuate, it cannot be that. Why cannot it be common and proper Palmar digitals? Come on, guys. Why not? Anyone?
Because they're branches of ulnar and radial arteries.
They are terminal arteries.
Exactly. All right. Okay. Next question. All right. A 69-year-old man comes to the office because of pain in his right.
What was the answer of the first last one?
Sorry,
Right
what?
answer. What was the right answer of the previous question?
It was the deep and the superficial palmar arch.
Okay. Yeah, because both arts communicate. Right.
Exactly.
Thank you. Thank you.
All right. Okay. All right. So a 69-year-old man comes to the office because of pain in his right leg. Pain starts in his lower back and right buttock and shoots down his leg, bursts when he tries to bend over. All right. Straight leg reproduces pain. Active dorsiflexion is weaker in the right foot. Flexion of the hip against resistance was normal. Decreased sensation in the plantar expert of the right foot. The nerve most likely affecting the patient passes between which of the following two muscles as it leaves its origin? All right, guys, a quick update that these types of questions are not asked on USMLE Step 1. I will take it up with Dr. Hamza and Dr. Ahmad before making this test because these are not, kind of asked on the exam. But if you don't know the answer, it's all right. If you don't know the answer of this one, but if you know, then it's a plus. But these are not asked on step 1. All right, do not focus your time on trying to remember the origin and insertions of muscles. They're not going to ask.
Okay.
Okay. All right. So what do you think the answer is? Even if you're wrong, it's okay.
Piriformis and superior
Piriform.
gemellus.
Piriform superior gemellus muscle.
Yeah.
Exactly. It's going to be piriformis and superior gemellus muscle. Again, if you got this answer wrong, it's okay. Just increase your 1 point in your exam because it's not this. These are the questions that are asked on USMLE Step 1. They barely ask you the origin and insertion of muscles. They usually ask you about nerves and muscle weaknesses. So it was just like a kind of an extra question over here. All right. 25-year-old track and field athlete presents to his physician complaining of right lower extremity weakness and an unsteady gait for the past 2 months. His symptoms worsen markedly with exercise. On examination, the physician notes atrophy of the medial portion of the right thigh and weakness to adduction. What nerve is involved?
Obturator nerve.
obturator,
Yeah.
adduction.
It's
All
for
right.
adductors, yeah. Mhm.
Exactly. What does the femoral nerve do?
Anterior aspect of the thigh, it supplies the anterior aspect.
Okay. What does the
The
sciatic nerve do?
flexion. Sciatic is posterior on the
Post,
anterior aspect.
yeah.
Posterior.
Exactly. What does the inferior gluteal nerve do?
Inferior gluteus supplies the gluteus maximus muscle.
Very
Yeah.
good.
Yeah.
And superior gluteal nerve supplies the gluteus.
Medius and
Medius and
Medius
minimus.
Medius.
minimus.
Very
medius.
good. All right.
Mm.
30-year-old woman presents to her doctor, severe knee pain. However, she does not recall falling. All right. Physical examination, tender effusion, X-ray shows a pathological fracture at the epiphyseal end. All right. Then we had the physician explains his concern that it might be a locally aggressive tumor. Which of the following is a diagnosis? What do you
Yes.
think the answer is?
GCT.
Giant cell
Giant
tumor.
Giant
cell
cell tumor.
tumor, yeah.
GCT.
Giant.
Why do you think it was giant cell?
Because it is epiphyseal in origin and it is locally aggressive.
Aggressive tumor.
These are the
That's
2
correct.
points which are characteristic of the GCT tumor.
Very good. That's very highly for you to remember, and that is why I said that the location of the bone is really important. Which tumors, like in diaphysis, we know that Ewing sarcoma is a diaphyseal tumor, and then osteoid osteoma is also a diaphyseal tumor. We know so where metaphysis, what are the metaphysis tumors? What are the epiphyseal tumors? It's really important, very high yield for you to remember. All right. Okay. Next question, 57-year-old teacher. She has arthritis, right hip pain for past 3 years. Pain is most severe at the end of the school day. Okay, they're talking about osteoarthritis. What additional finding is most likely in this patient? What do you think?
C.
Aorta
C.
nodules.
Exactly. Very easy question. Heberton Burkhardt nodes are characteristic of osteoarthritis. All right. Mother brings her
Sorry,
2 month.
Dr. Maheen, I have one doubt in question 21, the epiphysis one, I think 2020. Uh, in first aid, there's a sentence for giant cell tumor that the radiographic epicenter is in metaphysis. I don't understand that, and that's why I got confused here.
Okay, who is going to answer this? So,
It's a locally aggressive tumor and the epiphyseal. So these are the points and the young female lady. All these 3 points are going in the favor of GCT.
I understood that. Thank you so much for clarifying. I am asking, it says in GCT the radiographic epicenter is metaphysis. I didn't understand that.
Uh,
Is it because the metaphysis is just below the epiphysis?
So what they're talking about that it occurs in the epiphysis, and it kind of, because it's a locally aggressive tumor and it's a very aggressive tumor. So you in the initial findings of the X-ray, you will also see some findings on the metaphysis as well, and that is
Oh,
why it's not the point of origin; it is a point of spread they're talking about in first aid.
yes.
okay, okay.
Yes,
Thank
the
you so
point
much.
of origin should be from epiphysis.
Exactly.
It can involve and become aggressive to involve the metaphysis too.
Yeah, as
Exactly.
it's
That's what
just
they're talking
below it.
about.
Thank you. Thank you so
Okay.
much, Dr. Maheen and Dr. Mariam. Thank you.
All right, you're welcome. Okay, then we come to the 22nd question. Okay, a mother brings her 2-month-old infant to the ED because of lethargy, failure to thrive, fever. Physical examination reveals increased head circumference and prominent hepatosplenomegaly, profound anemia, leukopenia, display fluid resuscitation, initiation of antibiotic therapy, and the child dies, autopsy. Histological analysis of child's bone marrow space reveals a marked infiltration of the medullary canal space by primary bone spongious tissue. What is happening? What's this? What's this condition called?
Osteopetrosis.
Osteoarthritis. Yes.
Osteopetrosis.
Osteopetrosis, yeah.
All right.
Defective
Okay.
resorption of bone.
Exactly. And what do you see?
Osteoclast.
Osteoclast
Osteoclasts.
will be affected. Mutation of
Exactly. So we talked about this disease as well. It's also present in pathoma. If you guys still have any confusion, you can go through and read through the pathoma pages. All right. Next question. 58-year-old woman comes to the clinic for pain and stiffness in her hands. It is most of her fingers progressively worsened during the day and was relieved by rest and ibuprofen. Physical examination. Okay, now she has PIP and DIP both. Okay, which of the following is the pathological findings?
This is
Osteoarthritis.
osteoarthritis.
Yeah.
osteoarthritis,
And C.
osteophyte formation.
Osteophyte formation, yeah.
Exactly. So they're talking about osteoarthritis. Why? Because PIP and DIP are both
PIP are
affected.
involved, yeah.
All
Yes.
right.
Yeah,
What is
and
the
worsen during the day.
So can you repeat the question number 22, the previous one?
Is anybody saying anything?
Yeah, I'm asking if you could repeat the concept on question number 22.
Okay, so the question number 23 basically told us that there's a 58-year-old woman and she had
22,
stiff.
sorry. 22, 22. No, this one. 22.
Oh, you were saying 22?
Yeah, yeah, yeah.
Okay, they're talking about what? Osteopetrosis, right? Over here, they're talking about that.
Yeah, I think I kind of confused. Like, how did you tell it was osteoporosis?
Can it because of this? Because of this. And what else? What are the additional findings you see in osteopetrosis?
Cytopenia because of the medullary, all the cavity space that's filled up with the because of the overgrowth of the cortical bones, and we find the pancytopenia. So they have mentioned in this stem also the anemia and leukopenia. And the extramedullary
Extramedullary.
hematopoiesis, they have also mentioned here the hepatosplenomegaly. That's the
Very good.
extramedullary hematopoiesis.
So we know in osteopetrosis there is an inherited effect of bone resorption that results in abnormally thick and heavy bone that fractures easily. It is due to the poor osteoclast function. We know that, and because of those thick bones, we have bone fractures, we have pancytopenia, you have extramedullary hematopoiesis, you have vision and hearing impairment. All right. You also have hydrocephalus, that's the increased head circumference, right? You have hydrocephalus. Why is there hydrocephalus? Because of the narrowing of the
Defective
Magnum.
yeah.
Bone
So
resorption. Yeah.
exactly. You also see hydrocephalus. There's also RTA, renal tubular acidosis. You see that with carbonic anhydrase 2 mutation. And the treatment, unfortunately, it is only bone marrow transplant. It's the patient dies most of the times, 95% the child dies. So you have to kind of do bone marrow transplant. And yeah, because of pancytopenia, hydrocephalus, hepatosplenomegaly. Why hepatosplenomegaly? Because of extramedullary hematopoiesis. All of that fractures, all of that is kind of a giveaway for osteopetrosis, that is defective osteoclast. All right. Is that clear?
Yeah, thank you.
Okay. And then we come to question number 24. Skeletal system develops via process known as ossification, in which bones are created from pre-existing mesoderm. Which of the following is the name of the mechanism by which long bones of the limbs ossify, and how can the mechanism be described? What do you think the answer is?
Is the D or endochondral ossification? The bones form on the hyaline cartilage mold. In the
All right. Anybody else? Okay, so we know it's the endochondral ossification. Where do we? Okay, what happens in achondroplasia? What's happening in achondroplasia?
the endochondral ossification defect is seen.
Impaired ossification of the endochondral bones, which form the bones of the limbs. They are getting affected.
Okay, yeah, very good. Okay, next question. 9-month-old presents with they talked about achondroplasia over here. Okay. So what do you think the answer we talked about is a defect in the endochondral ossification? All right. We also know that it is because of the overexpression of FGFR3. It inhibits growth.
Achondroplasia.
We also know that they have shorter extremities with normal sized head and chest. And we know that the rest of the things like the fertility is not affected, the lifespan is not affected. It's the most common form of dwarfism. All right. Okay. Then we have the 26th question. You guys are doing very good. I'm really proud of you. Keep going. Okay. 24-year-old man brought to the ED due to right arm pain after a fall while rock climbing at a, okay, blah, blah, blah. I'm not going to read this. All right. Something snapped. He landed on his right arm and heard something snap. The patient did not strike his head or lose consciousness. All right. Okay. Vital signs are within normal limits. Physical examination shows extensive bruising over the lateral right arm and a total inability to extend the right wrist. All right. Mid-shaft fracture of the right humerus. What do you think the answer is? We talked about this.
Deep brachial
Deep
artery.
brachial artery.
Radial
Yeah.
nerve and deep brachial artery both injured in the mid-shaft fracture. Okay.
Exactly. So we
Yes.
talked about that the deep brachial artery gets injured in the mid shaft, humerus fractures. Okay, 23-year-old woman comes to the office with right knee pain after skiing incident. A coronal MRI of the affected knee is shown. Okay, what's this? What's this?
PCL
Posterior
attachment
cruciate
over the
ligament.
medial.
Yeah.
It is the medial condyle, and over the medial condyle, the posterior cruciate
Cruciate
ligament get
ligament.
attached. With the lateral condyle, the anterior cruciate ligament attached.
Medial.
Exactly. So this is a very high yield image. They also give you in UL self-assessments as well. So kind of be familiar with this image. They talk about where this is, like over here. We know that they talked about the posterior cruciate. This is the posterior cruciate ligament. You need to be familiar with the MCL, ACL, and just kind of see that picture. And it's very high yield. This picture is really high yield. All right. Okay, asterisk marks the attachment of which of the following. We know they're talking about the posterior cruciate.
Posterior
All right.
cruciate. Yeah.
Okay. 28th question. All right. The patient is instructed to stretch her arms forward and press her hands against the wall. When she does, the middle border of the right scapula lifts off the thoracic wall. That's the winging of the scapula. She's had recent hospitalization.
Yes.
All right. Okay. What do you think is that? Winging of the
During
scapula.
mastectomy,
Mastectomy, that's
Long-thoracic
really
nerve
mastectomy,
injury.
yeah.
axillary lymph nodes removal.
We know
Long-thoracic.
serratus
Long
anterior,
thoracic nerve.
serratus anterior, long thoracic nerve, and it usually occurs, injury occurs usually in patients who have undergone mastectomy with axillary lymph node removal. You see the winging of the scapula that's defined over here. All right. 29th question. Okay, second last question, guys, for today. 18. Okay, it is determined that the patient is experiencing a medication-induced dystonic reaction. I think we talked about that. The persistent myocyte stimulation causes a substance to be released from the sarcoplasmic reticulum. What is that substance called?
Troponin.
Calcium, and it binds with the troponin.
Troponin.
Exactly. So we know it is troponin. All right. We saw that picture in the URL as well. Okay,
Yeah,
what are
that's
they?
E.
Calf muscle, they have talked about that. Which of the following lipid regions contains only the thick filament and no thin filament? What do you think the answer is?
E.
Only thick.
You see, the
Myosin.
only thick filaments are over there. This picture is very high yield in the musculoskeletal as well. So the correct answer is option number E. And with that, we are finished with our assessment for today. Okay, guys, if you have any questions to ask, you can ask. Then Dr. Ahmed's class will start.
Dr. Maheen, so I understand you said yesterday's session was not recorded. I was listening in, but there were some questions like I lost signal. Is it okay if I message you separately and ask you what the word I'm missing is? If it's possible.
Okay, sure. You can do that.
Thank you so much. Thank you.
All right. Any more questions?
Yes, Dr. Maheen. I would like to ask you the questions on brachial plexus, the nerves and those stuff. I'm getting those questions wrong. So how should, like, is it just memorization issue or?
Unfortunately, it's only memorization. I mean, that's, these are the things I hate about musculoskeletal, the brachial plexus, the cervical plexus, the striatic, and all of the origin insertions. I hated that about musculoskeletal. So I understand what you're going through, but unfortunately, there is no other way that you can, kind of retain that information. You have to memorize it. And as much as you hate it, that's the only way you have to do it.
Okay.
Do you suggest ways of memorizing it, like Anki, or how should we do it?
There's only few nerves that they ask. I'll pin it in the group chat, and I'll like text you on the WhatsApp that what plexing you need to do, what like nerves are really important, like C5 is really important, C7, C6, some of those are really important, really high yield. So I'll like pin it, but that doesn't mean you skip the entire chapter and you don't do the entire brachial plexus. Go through that, but I'll kind of help you with what you need to focus on.
Thank you.
Okay. Yeah, anybody else? I got 2 minutes. Hmm. Okay, I have a request. Can you do rapid Q&A every day like yesterday, last 5 minutes? Very interesting. I have to think about questions. I keep on forgetting questions. It's really hard for me, guys. I gave like step one half a year ago, and 1.5 years ago I gave my step one. So but I'll try. I'll try. Next time when we finish the URL session, I'll have like 45 questions for you guys that you guys can participate in. It will be an interactive session so that it can help you. Okay. All right. Okay, so I think that's it for today. If you guys have any further queries, and you can, kind of Dr. Hamza, he can facilitate you with that, and he can reach out to me. And yeah, I'll see you guys tomorrow with the URL session. I think Dr. Ahmed's. Okay, so yeah, Dr. Ahmed is here, and he will take over your class. I will see you guys tomorrow. Till then, good day. Have a blessed evening wherever you are. And you guys are doing great, amazing scores. Don't worry, don't get disheartened if your scores are in your 60s, 70s. It will eventually improve. So it's completely fine. Do not feel dejected, demotivated. If you're scoring low, with a little bit of preparation more, you guys will able to pass step one. It's not rocket science, guys. It's an easy exam. It's not rocket science. It's very doable. You guys can do it. So don't worry about that. We'll help you guys with that. Okay, guys, I'll see you tomorrow. Dr. Ahmed is here. He'll take over.
Thank you so much. Thank you, Dr. Maheen, for having such an amazing session. Okay, so we'll be starting our session in 5 minutes. So you guys have 5 minutes. You guys can take your break, and then I'll be continuing with the new anatomy, right?
Right.
Okay, thank you so much.